Just to finish off T-spine and L-spine critique for 2024. T-spine positioning is a lot like chest x-ray positioning, where you put the top of the image receptor about 1.5 inches above the relaxed portion of the outer portion of the shoulders. Remember that some of your hospitals will use the T-spine or use the AP chest x-ray for a T-spine. So collimations depending on what you have going on. If you're doing a trauma series T-spine, then you very well may be using just a chest x-ray without any kind of collimation, collimated like a chest x-ray for the AP of the T-spine. Your phase of respiration is going to be on expiration, and what that does is it takes the lung and it collapses the lung in the upper portion of the thoracic cavity to kind of even out the tissue densities between the upper and the lower portion of the T-spine. So you want to put a bend in the knees to reduce the lordotic curvature. I know we have a tendency to stress that in the L-spine, but it really needs to be done in the T-spine as well, because the lordotic curvature begins in the T-spine, so that if you bend the knees, then it lowers the lower portion of the T-spine and the L-spine and puts it more parallel to the image receptor, so that you don't have that increased NOID and that misangulation of the vertebra. So like I've mentioned several times before, the wedge filters, the anode heel effect, saline bottle to even out the tissue density differences are not as significant as what they were with screens and films. Probably still a good idea to use the anode heel effect in as much as you can, but as far as using a wedge filter, it might have some benefit, but it's probably not worth the increased amperage through the x-ray tube and the wear and tear on the x-ray tube. The saline bottle, the reason I had this in here was because in the absence of wedge filter, and certainly if you didn't have a wedge filter, you didn't have the opportunity to utilize anode heel effect, maybe in a trauma room setup where everything is not ideal, then what you can do if you find yourself in a situation like that, and this is kind of like battlefield radiography, but what you would do is take the saline bottle and put it on the patient's sternum, and water finds its own level. So with the patient's sternum at an angle like this, where their head is up here, the upper portion of the saline bottle would fill with more water than the lower portion, creating effectively a wedge filter. So that would take the place of a wedge filter, a saline bottle would. And by bottle, I mean a saline bag. So evaluation of the T-spine, we want to look at the upper and the lower portion separately. The upper portion we would evaluate much like a chest x-ray, where we look at the sternoclavicular joints. On the lower portion, we're really looking at the difference in the appearance of elongation of the ribs. So what we also would want to look at is the lateral, so that we can evaluate the patient for compression fracture. So you're going to look at the AP to evaluate whether or not the patient has scoliosis before you repeat the lateral, but you're going to look at the lateral for compression fractures to see if maybe a compression fracture is causing a little bit of rotation. So what doesn't necessarily look like scoliosis may very well be almost like a pathological scoliosis. A patient with multiple compression fractures may have some rotation going on there that you can't straighten out. So sternoclavicular joints for the upper portion, spinous processes should be in the center of the vertebra, but you can also look at the ribs, the appearance of the ribs, if you've not collimated in so much. Spinous process should be in the center of the vertebra. As we have rotation, the spinous process is going to go towards the elevated side. So with a LPO, if you're shooting an AP T-spine, then what you're going to see is the spinous process projecting out laterally on the right-hand side. So when we talk about scoliosis, you can't overcome rotation because of scoliosis. So you've got a couple of different things there. First off, in true scoliosis, you've got a primary curvature and then you've got a compensatory curvature. So the body tries to recenter itself over the trunk or over the center of gravity. So where you've got a curvature away from the midline, the body tries to recorrect it and put it back over midline. That's why you truly have that S curve. But you can also have what we refer to as dominant arm scoliosis, and that's not truly scoliosis, but what you may see in some of your patients is a tilt of the very upper portion of the T-spine. And that's usually because of overdevelopment of the muscles on that side of the body. And where that occurs is where a patient or a person carries heavy objects primarily on one side or the other. So what happens is that the weight is pulling them down on one side, and their body, to try to shoulder that weight, they'll lean in the opposite direction. So that will overdevelop some of the musculature on this side and cause, it's not really rotation, which is what you see in scoliosis, but it's just a tilt. It's overdevelopment or a hypertrophy of the muscles on that opposite side, causing a little bit of a tilt. And it may give you a false impression the patient's got mild scoliosis, where in fact they do not. So lateral T-spine, the image receptor positioning is, again, much like on a chest x-ray, you have a difficult time seeing the very upper portion of the T-spine, but you can see the lower portion quite well. So just like on a chest x-ray, you might center a little bit lower for the lateral to make sure that you don't clip the bottom of T12 or at least so that you can see T12 L1. So your centering is going to be to the really a little bit posterior to the middle of the patient's thoracic cavity. So you're going to have a tendency to want to center directly in the middle of the patient. So you got this patient with this big barrel chest, and you're going to have a tendency to want to put your image receptor in central ray right dead square in the middle. But keep in mind that the patient's, what we're looking for is the T-spine, which is in the posterior portion. So mid-axillary line is a good centering point, possibly even a little bit posterior to that, maybe right at that skin fold on the posterior portion of the patient's body. So right behind the upper portion of the humerus or the upper arm. So, but also take a look at the patient's their body build, and if they have it doesn't necessarily have to be a kyphotic appearance, but if they've got what looks like a greater than normal bow in the back, approaching kyphosis, then you might want to keep your collimated field open just a little bit. You might collimate the upper or lower portion of the T-spine off. So what we see on lateral T-spine is the height of the vertebra, and we can evaluate for compression fractures. We'll take a look at compression fractures and what they look like here in a bit. We can see subluxation, and most of the time subluxation is going to be anterior to posterior, but sometimes in very high-speed collisions you can get lateral subluxation, where you get total separation of the spine side to side. And where mild subluxation anterior to posterior sometimes is correctable, and the patient won't have ongoing neurological issues. Side to side, the patient's that's devastating. Not only is it devastating to the neurological system, but it possibly is going to be devastating to the cardiovascular system. Just imagine all that trauma enough to separate that laterally, where you've got you've got the descending aorta, eventually into the abdominal aorta, and also the vasculature coming back up, the inferior vena cava. It could be devastating. So lateral subluxation is always bad. So remember our obliques and our laterals. On lateral, on the T-spine, we're going to see our intervertebral foramina. So the T-spine and the L-spine are similar in that respect. But on our obliques, on our T-spine, which are rare, I don't know that in my entire career I've ever shot an oblique T-spine, but on your T-spine, on the obliques, what you're going to see is zygapophyseal joints. So lateral, you're going to see the intervertebral foramina. The obliques, which are going to be steep obliques, especially in the upper portion of the T-spine, 60 to 70 degree obliques, so approaching a lateral, you're going to see the zygapophyseal joints. So collimation, again, you want to utilize collimation in as much as you can. Just don't collimate off the anatomy. You can also use, to clean up some of the scatter radiation behind the patient, you can use a lead shield behind the patient on the tabletop. The breathing instructions are always going to be, to allow the patient to breathe, so you're going to use breathing technique. To get an adequate breathing technique, you really need more than a second, more like 3 seconds, but sometimes you're kind of limited in that. If you have a smaller patient, or if you're using a portable where you can't select your MA and your time separately, breathing techniques are a little bit more difficult to achieve. So what you might be able to do for a breathing technique on a portable machine is one of two things. One is not really good for the patient. You're going to reduce your KVP, which is going to give you a larger mass value. Don't really recommend that. What I would recommend is something more like a limited breathing technique, where you have a patient taking a big deep breath and tell them slowly blow the breath out and shoot during that exhalation. So remember in Merrill's we talked about our patients with broad shoulders and narrow waist. You may have to build the patient's spine up in order to visualize the vertebra in a true lateral. And what you'll see on a vertebra is, let's see if I can make this work. So this is a speaker. So imagine this being a vertebra. And a vertebra on X-ray looks square. And this kind of looks square on a camera as well. But if we oblique it a little bit, what you start to see is the ends of the speaker. The same thing happens with a vertebra. So if your central ray is perpendicular to your vertebra, the vertebra appears square, as opposed to if the vertebra is tilted compared to the central ray, then you start to see the end of it and you start to see it's actually rounded. If you're ever working in surgery and you're using a C-arm and your doctor tells you that his vertebra, he can't see him very well. He's putting screws through the pedicles into the body. He needs to see a good lateral she. It just so happens that I've only ever worked with male neurosurgeons or orthopedic surgeons, but it could be she. But what they may use a word called coplanar, and it's spelled just like it sounds, C-O-P-L-A-N-E-R, coplanar. And the doctor will say, well, you're not coplanar. And he expects you to know what that means. And what that means is that you're not perpendicular to your vertebra. And he's seeing that. So what you need to do is put your C-arm more perpendicular to your anatomy. So that that wag of the C-arm, you need to adjust that. How that relates here is that if you don't build the patient's spine up, if they've got broad shoulders, narrow waist, for a T-spine, you'll see the same thing. Your vertebra won't be round or won't be square. It'll have that. You'll start to see the end caps, and it just distorts the vertebra. So you need to build it up or angle your central ray, one of the two, in order to correct for that. With a T-spine, you always include a swimmers. On a C-spine, remember that you only included swimmers if you didn't get down to C7T1. With a T-spine, it's always included. It's kind of like the open mouth odontoid for the T-spine. So C-spine, you might use it, you might not. On a T-spine, you're always going to use it. So your technique is always going to be specific to your machinery, but in my practice, a lateral T-spine, lateral L-spine was always going to be about the same, roughly, and that was going to be around 80 at 80. You could apply that also to surgical lateral hips and swimmers for your average size patients. So, find one patient that you consider average, figure out what good technique is for that patient. The distance between here and here, and between here, and then lateral L-spine and surgical lateral hip is very similar. So that technique should be a baseline for all four of those different projections for you. If you're phototiming, you might want to consider hitting it with +2. They, in my experience, always came out a little light if you didn't use a +2 density. And then as you detect rotation, remember what you see on oblique, because that's effectively what you're getting with a rotation from a lateral. You start seeing the zygapophyseal joints, then you've got some obliquity going on, some pretty significant obliquity. So obliques, not going to spend a whole lot of time on this, just because there's, again, in my entire career, I've never shot an oblique with a T-spine, not on purpose anyway. So your film centering, or your image receptor and centering, is going to be our positioning is going to be very similar to what it was on an AP or a lateral, but your centering is going to be, if you're shooting AP, is going to be towards the elevated side, so about halfway between the patient's sternum and their lateral border. Degree of obliquity depends on if you're shooting the upper portion of the T-spine or the lower portion. We have a tendency to think of the C-spine, the T-spine, and L-spine as being there being just a magic change from C-spine to T-spine, T-spine to L-spine. And that's not really the case. If you think about your C-spine and where you see your zygapophyseal joints, they're at 90 degrees from AP, so they're at lateral. T-spine, they're at 70, and then when you get down to the L-spine, the upper portion of the L-spine is closer to 45, lower portion is closer to 30. So what you get is this gradual change from one end to the other. So your upper portion of the T-spine is going to require a steeper degree of obliquity. You got your 70 degrees. Lower portion, you might consider backing it down to 60, possibly lower than that even, if you specifically are looking for the zygapophyseal joints in the lower portion of the T-spine. So L-spine, the reason I have PA in here with question marks is that you might run into a registry question that asks which projection could we shoot the L-spine in that would put the intervertebral disc spaces more parallel to the divergent central ray, and that would be a PA. So consider the L-spine. The L-spine, especially with the knees not bent, it's going to bow towards the X-ray tube, which is going to take your intervertebral disc spaces, and you might have one or two that are pointing up, and the rest of them are going to be pointing out at an angle. So if we shot them PA, it's kind of like shooting the AP of the wrist. We get better joint spaces in the AP of the wrist because of the shape of the wrist bones. But in an L-spine, we would put the disc spaces more parallel to the central ray if we shot a PA. Realistically, you're probably never going to do that. You're going to increase OID if you do that, which decreases sharpness or recorded detail. Your better bet is to bend the knees, but you're going to run across that question about PAL spine in registry review books, and that indicates that it might be on the registry. So your centering is going to be pretty specific to your collimated field. So if you're working in a hospital that likes to shoot your L spines more like a KUB, it's going to be a 14 by 17 collimated field. And you can center at the crest. If you're using more like a 11 by 14, which would be collimated down to something more like a 7 by 14, just for the L spine itself, you might need to go about 1.5 inches, 2 inches above the crest. So if you're working in a hospital where protocol is to shoot KUB for the L spine, then by all means shoot it on 14 by 17. I prefer collimation, so if I'm working in a hospital that doesn't specify that that's what they want, then I'm going to use a much more collimated field. Remember the rules of collimation really are the field needs to never be larger than the image receptor, and the anatomy should determine the size of the field. So if you're just looking for the L spine itself, then you need to collimate. But the flip side of that is that if you over collimate, remembering the purpose for collimation, if you over collimate and you clip anatomy that you need to see, you've done the patient no favor. Collimation main purpose for collimation originally was elimination of radiation dose to the patient. So if you over collimate, you clip anatomy, you've got to repeat, and you've doubled the patient's dose. All right, so if the patient's on a backboard, they stay on a backboard. If they have scoliosis, then remember you can't get rid of collimation, or you can't get rid of rotation, rather, with a patient with scoliosis. We've done this to death, so I'm not really going to talk about that anymore. Reasons not to collimate for an L spine. All right, so we're also going to evaluate our L spine on the upper and the lower portion as well. For the upper portion, we're going to look at the ribs, and if they appear to be rotated, we're also going to look at that spinous process and whether or not it's in the center of the vertebra. And just like on the T-spine, if we have a rotation, the body of the vertebra is going to go in one direction, and the spinous process is going to go in the opposite direction. Remember, you can't get rid of rotation with scoliosis. Also, evaluate your lateral for compression fractures before you get too uptight about rotation on the AP. Also, evaluate your AP to see if there's any obvious scoliosis before you repeat any laterals. All right, so the obliques, again, we're going to be looking for the zygapophyseal joints. And what we see on the obliques of the L spine, remember your Scotty dog. So your zygapophyseal joint is formed by the ear and the leg of the two vertebrae. So the ear is going to be the portion that is going to be the superior articular process of the vertebra below, and it should be right there with the leg, which is the inferior articular process of the vertebra above. So that's what we're going to be looking at. The eye, we're looking straight down onto the pedicle. The nose is the transverse process. The neck is what we refer to as the pars interarticularis. But really what you want to see in your degree of obliquity, or to determine your degree of obliquity, is the nose should come right to the edge of the vertebra. All right, so your spinous or your transverse processes are pointing laterally. Right, so as you rotate up, let's say there we go. I'm lopsided. All right, so as you rotate up, look what's happening with my thumbs compared to my body, right? So my shoulders, as I rotate up, the nose, this is backwards, so the camera view is backwards. So as I rotate up, what I should see is my nose right at the edge of my vertebra. Vertebral body, nose. That's a transverse process. So we've got nose right at the edge of the body. So that's what you should see and where it should be. If our nose is sticking too far out from the body, what that indicates is the patient is too AP. If it's too deep into the body, we're moving too close to lateral. So I hope that's helpful. If the nose is right at the edge of the vertebra, you're golden. If it's too deep into the vertebra, you've gotten too lateral. And if it's poking out from the vertebra, from the body of the vertebra, then you're too AP. So that's what I just talked about, so I'm not going to go back through that. Lateral, again, don't overcollimate, but what you should see, I'm going to skip down to an image down here, but what you should see in a lateral, what you should be able to use in a lateral to determine where to position is the highest point of the iliac crest. All right, so highest point of the iliac crest is always going to go right across, right back here, right around the, this is a little bit further back because this patient has spondylolisthesis, but it should go pretty much right up and down through the posterior arch. So what you do is you find the highest point of the iliac crest and you put this line of collimation right on the highest point of the iliac crest, and you collimate into a relatively small area. Easy to overcollimate on a lateral L spine, so just be aware of that. Be careful of that. But if you put this longitudinal line of collimation right on the peak of the iliac crest, you're going to get pretty close to the center of the overall vertebra. It's not going to be the center of the vertebral body. It's going to be a little bit posterior. And again, in that, you may have to use a +1 density setting on your machine. So, try to get back to where we were. Okay, so now if we have a patient, so in the T-spine, the problems that we run into with the non-coplanar vertebra are men, so wide shoulders, narrow waist. On L spines, we have the same problem, but it's with women. So it's usually the worst with thin women because you got this little bitty waist and you got the more broad hips, and so the lower portion of the L spine is not parallel to the image receptor and tabletop, and we get that same appearance. It looks pretty drastic again in thin women. So you either need to build up the L spine, which is really preferred to angle in the central ray, but if you can't build up the L spine, then you might consider angling the central ray. Now notice, if a patient's cross-table lateral, you don't have to do any of that. For the most part, the L spine is going to be pretty straight. So that's just if you've got a patient laying on their left or right side. You can also use lead to absorb some of the scatter radiation that's coming off of the patient that might hit the image receptor behind the patient. And again, your technique is going to be pretty specific to your machine. Stack the patient's knees and ankles on top of each other if they can put their knees and ankles on top of each other. If you've got one in front of the other, it's going to introduce just a little bit of rotation. If you got knees in front of, one knee in front of the other, it can be pretty significant, rather. So one other view that you must shoot for a lateral is what we call spot film. And a spot film is whenever, again, you've got narrow waist and wide hips, and you can't really see through L5S1 very well, then you might consider shooting a spot film. And all spot film is a small image of L5S1. So the best way to position for that is to take the kind of this knife edge of your hand and put it just above the patient's iliac crest and fold your hand down onto their, over the top of their iliac crest. And you put your central ray right in that crook of your hand right there. Hit it every time. So on the lateral of the L-spine, we're going to see that intervertebral foramina. Our evaluation, we're going to look for that coplanar, whether or not the vertebra is parallel. But also, we're going to look for rotation scoliosis. Look at the rotation of the upper portion and the lower portion. Have the patient, and it's hard for some patients to get into a good lateral position with both the upper and the lower portions. So I'd have the patient put their arms out in front of them to kind of stack the upper portion of the anatomy on itself, put the knees on top of each other, the ankles on top of each other, and you should be pretty good. But you can evaluate rotation again just by the appearance of the vertebra. And the lumbar vertebra, without really anything to superimpose it and make it look odd, it becomes pretty obvious you've got rotation pretty quickly. But it might be helpful to look at the pelvis to determine which way the patient's rotated. So if you can see the humeral heads, then of course the one that's furthest away from the image receptor is going to be magnified. So the fat one being anterior, then what you've got is you've got rotation towards the table. And if the fat one is the larger humeral head, I said femoral head, is posterior, then the patient's 2AP. So that would be one way, but just the appearance of the iliac wings as well, you should be able to determine rotation in that as well. So fractures, T-spine and L-spine, we talked about some of these. You've got your subluxation, but you've also got compression fractures. We're going to take a look at that. You looked at spondylolisthesis, but we'll take a look at that again as well. So in your compression fracture, you got three different pillars. You got anterior, posterior, and you got middle. And the severity of the compression determines the severity, the number of pillars determines the severity. So if you've got one pillar compressed, it's pretty stable. If you got two pillars compressed, that would either be an anterior and middle or a posterior and middle. Then it becomes a little bit more unstable. It's going to lead most of the time to kyphosis, or it could be lordosis, but kyphosis most commonly is what am familiar with. Now, what they can do for compression fractures of both the T-spine and the L-spine, I don't have any images of it here, but I want to show you what they can do. So what we have in the anatomy, we've got the body, and we've got the spinous process, and we've got the pillars right here, or the pedicles rather, and then behind that we've got the lamina. So the lamina come together to kind of, connect the anterior and posterior portion together. And they kind of mash together and create the spinous process, so to speak. So what they can do, though, is they can run a kind of a trocar, a sharp instrument into the body through the pedicle into the body, and they can inject some cement. Sometimes they'll put a balloon in there to kind of reinflate the vertebra, and then put cement in it to give it strength. And so when I used to work in surgery, they were just getting into this type of technology. And I've seen compressions that were really significant, that they were able to bring the vertebra back to almost its original height. So what we have here is a subluxation. This is spondylolisthesis. And what it is a subluxation of L5S1. And it can cause some back pain, but the more it's not as dangerous as what it looks like. It causes back pain, sure, and it is subluxation, yes. But compared to subluxation, let's say of T12L1, it's not as significant. And the reason for that is because you've got to remember where your spinal cord ends, what the cauda equina is. You may still have some nerves coming off, but the spinal cord all by itself, or the spinal cord is a single nerve bunch, has ended well before this. So painful, yeah, but in some patients, believe it or not, this is incidental finding. So you may see something like this on a patient who's not even complaining of back pain. And let me see. So compressions, you got a compression fracture there. So you've got a couple of pillars involved. It's a little bit unstable, and it's probably not as bad as a lot of compression fractures, but it's still not good. And so what you can have, okay, so this is what we'll call a lateral listhesis in a scoliotic patient. And what you can have is scoliosis is so significant, you can have some of this subluxation because of the scoliosis. So it's subluxation without compression fractures, and it is subluxation, in this case, a lateral subluxation without trauma. So anyway, hope that's helpful. Final exam tomorrow. Sorry I'm getting this out so late. It was a busy week last week. Had a lot going on. Advisory committee meetings and lots of big meetings. And to be honest with you, I just completely forgot about it. So hopefully this is helpful. I'm going to put this up without editing it. So if there were any other mistakes aside from the couple I caught, I apologize.